Today's webinar is titled Stroke Triage, Transport, and Treatment with SNIS's Get Ahead of Stroke campaign. I'm going to pass it over now to Camille, who will introduce our speakers. Thank you so much for being here with us today, everybody.
Hi, everyone. My name is Camille Jewell. On behalf of the Get Ahead of Stroke team, we'd like to thank you guys for joining us today, taking the time to learn about our campaign. And so I would like to introduce our speakers today, Dr. Fifi and Dr. Jayaraman. They will be taking us through latest in stroke triage, transport, and treatment. Like Rio said, any questions we will answer at the end during a Q&A. So make sure to jot those down, and we look forward to hearing from you guys at the end. So Dr. Fifi.
So welcome, everyone, and we're really glad to be here to share what is a passion for all of us, which is taking care of stroke patients. And so I am Johanna Fifi. I'm an interventional neurologist and president of the Society of NeuroInterventional Surgery, and I'll be speaking for the first half, and then Dr. Jayaraman is going to speak for the second half. So at the end, just to run through the objectives, at the end of this webinar, you all will be able to understand stroke prevalence in the United States, as well as the different types of stroke and applicable treatments for the types. And especially for you, the purpose of stroke scales and pre-hospital management for ensuring successful patient outcomes. Also, we'll go through some of the latest research on thrombectomy for severe strokes and the benefits of using severity-based triage and transport. And we will share some free tools and resources for EMS providers that they can use in the field. Next slide, please. So we're going to go through the stroke in the United States, some facts. So as you may know, stroke is a leading cause of death and long-term disability in the United States, and it's pretty common. Every 40 seconds, someone has a stroke. There are more than 795,000 people in the United States having strokes every year. Stroke kills about 140,000 people a year, and that's 1 out of every 20 deaths. The vast majority of strokes, 87%, are ischemic strokes. That's caused by a blood clot blocking a blood vessel in the brain and depriving the brain of blood flow. Here is a map showing in dark purple what we call in the field the stroke belt in the United States. So the South has very high incidence of stroke death rates, and it's a little bit less in the Midwest and in the Northeast. But if you work in those areas of the country, you'll see a more frequency of stroke patients in the field. Next slide. And so stroke is ischemic stroke caused by a blood clot in the brain, can affect different parts of the brain, and depending on the part of the brain that's affected, patients present with different symptoms. So if the clot is blocking blood flow to the left hemisphere, so we frequently, you may hear the term left MCA stroke. It's left middle cerebral artery stroke. Patients will have a left gaze preference, so their eyes will be deviated that way. They'll have a right visual field deficit, so they won't be able to see anything on that side. They'll have weakness on the right side in the arm and the leg, and they can have sensory loss, so they won't be able to feel touch or pain or temperature on the right side of the body. Face, arm, and leg can be affected. And then if it's affecting the right hemisphere, it's different. So it's pretty much the opposite: a right gaze preference, left visual field deficit, left hemiparesis, and left hemisensory loss. If the stroke is from a blockage in a blood vessel to the cerebellum, which is the lower back part of the brain. Uh, that's the part of the brain that controls coordination. So they'll have truncal or gait ataxia, limb ataxia in coordination. They can have neck stiffness. And then the brainstem, that's a little bit, as you can see, the print is small and there's lots of words there. So this type of stroke is actually the one that is most commonly missed because it can present with a variety of different symptoms. So things like nausea and vomiting, double vision, dysconjugate gaze, or trouble moving your eyes. They can have slurred speech, dysarthria, dysphagia, trouble swallowing. They can have vertigo and tinnitus, hemiparesis, or even quadriplegia if it affects a large part of the brainstem. And sensory loss can occur in any of the limbs. And then eventually, if it's the most severe of brainstem strokes, patients will begin to become lethargic, decrease consciousness, and sometimes become comatose. You can have hiccups and abnormal respirations as that is happening. Next slide. And so as I said, brainstem strokes are sometimes missed, and so it's important to keep a high suspicion for that. And then on the other category of stroke, which is about 13% of strokes, so less, is hemorrhagic strokes, and that's when instead of a blood clot blocking blood flow to the brain, the blood vessel ruptures and there's bleeding into the brain, and that can present with focal neurologic deficits, the same as in acute ischemic strokes, depending on which part of the brain is affected. There are different types of hemorrhagic strokes, but a common or one type is called subarachnoid hemorrhage, and that's when blood leaks into the lining of the brain, and that presents with a very severe headache. Um, all types of hemorrhagic stroke typically do have, patients typically do have some headache, sometimes neck pain, light intolerance, nausea, vomiting, and often a decreased level of consciousness. Next slide. So the risk factors for stroke when you're taking a history from the patient or the patient's family, these things can kind of tip you. So there's things that you can modify, like things that you can try to control, like high blood pressure, cigarette smoking, diabetes. If patients have a known history of carotid plaque, peripheral artery disease like plaque in other parts of the body, atrial fibrillation, or other types of heart disease, sickle cell disease, high cholesterol, poor diet and physical inactivity and obesity are all modifiable risk factors. Some non-controllable risk factors, age, stroke frequency increases with age. Sometimes there's heredity, so it runs in the family. Race, gender, and then anyone with a prior stroke, TIA, or heart attack is at higher risk of having a stroke. Next slide. Um, and so it's important to rule out stroke mimics, or sometimes you can't rule them out, but to keep them in mind. So hypoglycemia can present with focal neurological deficits. So we check a finger stick. Intracranial mass lesions like brain tumors can cause symptoms, seizures, and postictal states. Some patients will develop a Todd's paralysis, so they may have a hemiparesis after a seizure without a stroke. Sometimes that can be very difficult to tease apart and requires imaging. Migraine can sometimes mimic a stroke. Some patients have functional hemiparesis or the functional neurological disorders. And then encephalopathies and other toxic metabolic conditions can look like stroke at times. So in the field, it's a lot of things to keep in mind, a lot of differential. But stroke is a very time sensitive disease, and so it's very important to be able to be able to identify patients with potential stroke and then triage and transport to the right location. So there's a lot of tools that we use, which are stroke scales, tools that can be used in the field. So if you guys could answer in the chat what type of stroke scale is used in your area for assessing potential stroke patients in the field. So some examples are LAMS, LA Motor Scale. In New York City, where I work, we use something called SLAMS, which is LA Motor Scale plus speech. CSTAT, MEND, FAST-ED, Cincinnati, stroke scale, race, those are all different options. Okay, I see that we have actually the full gamut here. And so yeah, people are using MEND, Cincinnati, FAST-ED, BFAST. Yeah, so VAN is actually not on our list, but that's a stroke scale as well. So so of all of these scales, do all of the stroke scales detect severity of stroke? If you guys could answer yes or no. No, yeah. So that's true. Everybody's saying no. So good. We have a smart a smart crowd. You guys already know all this. So yeah, because the more severe strokes, we'll get to that in a little bit. There's a very specific treatment that can only be done in certain centers. So it's good. It is important in the pre-hospital setting to be able to detect severe stroke so that you can transport the patients appropriately. And LA Motor Scale does detect severity. It's fairly quick to administer. There's basically three things you're looking for: face, ask the patient to smile, see if one side is weak. Arm, ask the patient to raise up both arms. If one side doesn't move at all, you get 2 points. If one side's weak, then you get 1 point. And then for grip, the same thing, weak or doesn't move. The LA Motor Scale greater than 4 carries an over 7-fold increase in risk for large vessel occlusion, which we'll get into in a little bit. Next slide, please. The Cincinnati Pre-Hospital Stroke Severity Scale does not detect severity, so it's basically the similar face, arm drift, and in this case they add speech. So slurring or saying the wrong words will give you a point. And so it's basically a screening tool. And so the CSTAT is applied if you get a score of 2 or more in the Cincinnati stroke scale. Next slide. So once you suspect stroke and you're transporting the patient to the hospital, there's information that should be gathered at the scene so that this can be reported to the emergency department. And the best practice is to have a report that's given on the way to the hospital. And so the patient's age, sex, and weight is very important. The weight is needed to dose the thrombolytic or the medicine that's used to dissolve clot. And then mechanism of injury or medical problems, just history, the chief complaint, a brief history of what happened, vital signs. Very importantly, because the administration of the medicine and to some degree the performance of thrombectomy um, is um, is sort of dictated or informed by when the patient is last known well. And so sometimes if the patient is unable to talk or doesn't know it for themselves, it's important to ask at the scene, when was this person last known to be well? Sometimes patients may go to sleep and then they wake up with symptoms. So it's important to note that the last well was last night as opposed to when they wake up with the symptoms. And then the level of consciousness, general appearance, cardiac rhythm, if they're an AFib, and then any medications or interventions that are performed by EMS, and then ETA. So the more critical the patient, the earlier you need to notify the receiving facility. So in New York City, where I work, they do a pre-notification and they call through the command center to be able to bypass the most severe stroke patients to accurately uh, transport them to the patients that can, or to the hospitals that can perform thrombectomy. Okay, next slide. Yeah, and so while I'm sure you guys all know this, but when you're assessing the patient, ABCs is always the first thing: airway, breathing, circulatory status. And then checking the glucose when you have focal neurologic deficit is important. A full set of vital signs, get the patient's medications, a 12-lead EKG, and then establish IV access. Um, the the medication that is used for dissolving the clot, it was TPA was the only FDA approved medication until recently. Now tenecteplase is available, but they're both strong lytics. And so there's some absolute contraindications where you cannot give it. So it's important if you know, if you get a history of this, this is reported to the emergency physicians if the patient's or their family is unable to accompany them. So any active internal bleeding, any recent intracranial or interspinal surgery or serious head trauma, any intracranial conditions that may increase the risk of bleeding, bleeding diathesis, severe uncontrolled hypertension. Currently, the blood pressure has to be less than 185 to administer the lytic. Current intracranial hemorrhage, of course, and subarachnoid hemorrhage are contraindications. But the intravenous medication, which can be given at primary stroke centers, don't work for the ischemic stroke patients who have a severe stroke, known as an emergent large vessel occlusion, LVO or LVO. And for this specific condition, patients require treatment with a procedure called thrombectomy. So, yeah, so the types of occlusions that this is all right, this is a image showing the types of large vessel occlusions, and you can have these in the big vessels of the brain. So this is a middle cerebral artery occlusion on the left, and this is the cutoff here. This vessel should continue, and then this is a basilar artery occlusion that causes those brainstem symptoms. And then this is a cutoff of the internal carotid artery completely, which can cause a very severe syndrome on the right side. Let's see what the next slide is. I think at this point, Mahesh, are you gonna take over here and talk about
Yep.
thrombectomy?
Yeah, perfect. Thanks, Joanna. And I'd like to thank everybody that's joined on. And now we're going to talk about, if we go back to that previous slide, I'll just show, yep. And, what we were showing here is there's areas where there should be blood flowing, but it's not, right? So there's a blockage. There's a blood clot that's occluding those areas. Can we go to the next slide, please? And what is thrombectomy? So thrombectomy is a procedure performed by neurointerventional specialists like myself, Dr. Fifi, and our colleagues, where we use catheters to quickly reopen these blocked arteries in the brain. And this procedure can be done incredibly quickly in as little as 20 minutes. And we now have essentially a decade of evidence showing randomized trials that have shown that doing this procedure very quickly significantly improves outcomes. Now, initially, we just focused on the patients with blood clots in the front part of the brain in the first 6 hours. We then showed that we can do this safely out to 24 hours. We've then shown that we can show this in patients who have occlusions in the back part of the brain, and even in patients with occlusions in the front part of the brain with what we used to think was too much damage or large infarct core. Can we go to the next slide, please? And just how important is time? So your brain, for every minute in which stroke is untreated, loses about 1.9 million neurons. And if you think about it in the standpoint of a patient-specific outcome, every minute delay to thrombectomy costs the patient about a week of independent life. So let's go to the next slide. So what can we do? We can actually triage patients to the correct hospital. This is data from research we did in our area in and around Providence, Rhode Island, and it shows something very important, and that is that if you go to the closest hospital first, and this is over 5.5 years, even with an understanding of the importance of rapidly identifying patients, even with the importance of understanding how quickly we have to move, over 5.5 years, without going directly to the closest, rather just by going to the closest hospital, there was essentially no change in time to treatment over 5.5 years. In contrast, if you're willing to drive patients to the appropriate hospital, to a center that can do the thrombectomy, there was a dramatic drop, almost a 40% decrease in time to treatment. And if we go to the next slide, we can see that these rapid changes and reductions in time to treatment resulted in significant improvements in patients who were independent at 90 days. In fact, if you go straight to that comprehensive stroke center, almost 1 out of 5 patients with severe stroke were what we call a Rankin 0, which means no symptoms, back to work. They're twice as likely if you go directly to a center that can do the procedure. We go to the next slide, please. So that thrombectomy is such a profound therapy. And now, as I said earlier, we've shown now that you can do this procedure up to 24 hours in some patients from the time last known normal. And if you get thrombectomy quickly, patients can increase their life expectancy by 5 years, at least twice as likely to be independent. And as I said, you gain a week of healthy life for every minute saved in getting them the appropriate care. So how do we do that? Well, ideally, everybody with a large vessel occlusion should be treated at what we call a level 1 stroke center or a comprehensive stroke center, which offers the full spectrum of neuroendovascular care, including thrombectomy. These centers, like the ones that myself and Dr. Fifi work at, have teams on call, standby, 24/7, 365. Almost all of us have 2 teams on call at any time, so we can handle 2 of these types of patients at once. If there's no level 1 stroke center available, say within 2 hours, then it's very reasonable to go to and develop these level 2 stroke centers, which are thrombectomy capable centers. Go to the next slide. But here's the challenge. Less than a third of eligible patients do not receive thrombectomy, and several states do not have protocols for first responders to transport severe stroke patients directly to a level 1 center. And others have protocols but are not implementing them. So while we go to the next one, why don't we take a look and see what happened? So back in 2016, there was only, let's go back to the beginning of this slide, one state, Little Rhode Island, that had actually modified protocols. But over the course of this last 9 years, we've seen dramatic improvements such that you can see the majority of states have some amount of severity-based protocols. They either have a statewide protocol or at least regional protocols. So I'd be curious in the chat, how many of you, if you could just put in whether your state, either on a statewide basis or on a region by region basis, has some form of severity-based triage protocol. We're down to just a small handful of states that don't have any protocol or anything in place. I'm really excited that we've made such tremendous progress. So New Hampshire's got statewide, we've got some regional, we've got some statewide, and that's great. These protocols are really helping patients. Can we go to the next slide, please? So what are the solutions? Well, first and foremost, we need to get these large vessel occlusion patients the treatment they need at level 1 centers. We're very close. We've made tremendous progress. Again, we started out with one state. We're down to just a handful left, but we really want to finish the job and update EMS protocols in all 50 states to ensure that most stroke patients will survive stroke and thrive. This is why we're here with you guys. You guys are the EMS professionals and educators. We want you to know what we feel is really one of the most impactful things we can do to improve a patient's life. And we also want to educate consumers. There are certain regions where consumers are reluctant to call 911, especially if their symptoms are more mild. And unfortunately, as we all know, sometimes the mild symptoms can just be the tip of the iceberg and things can happen very quickly. We go to the next slide, please. So the paradigm here is probably closest to trauma, right? Where patients are evaluated according to a standardized criteria. And based on combination of EMT assessment plus mechanism and location, patients are taken to the most appropriate center. Sometimes it's a level 1 center, sometimes it's a level 2 center. If both of them are equidistant, most times patients will go to the higher level center, and those patients get the right type of treatment. A big difference between trauma and stroke is that in trauma, sometimes we take a patient to a level 1 center and they end up just having minor scrapes, and we say, oh, thank God that's all it was. Whereas in stroke, to this day, we will triage a patient past a lower level center directly to a level 1 stroke center. And then it turns out the patient wasn't having a stroke, and people still seem like upset, like, why did we transport? No, we have to think like trauma. Thank God it wasn't a severe stroke. We go to the next slide. And so this is what we're saying is this is that red step, the transfer. That's what's really hurting stroke patients. There's too much time lost if the patient is taken to a center that cannot care for the severe stroke. Go to the next slide. And do the stroke patients honestly, truly deserve anything less? They don't. So we really want to try and have stroke protocols mimic whatever possible trauma protocols. It's a field assessment, and you take your best guess and you go to the highest level center that you can safely transport that patient to. And if the patient ends up not needing the resources of that level 1 center, we say, gosh, that's great. It didn't turn out to be a severe stroke. Go to the next slide. Now, some of you may have seen that there were some trials that were published a couple of years ago that were interpreted as there's no benefit to bypassing closer hospital. And if anyone saw this, please just throw it in the chat. But we have to look at the fine print. And if you look at the fine print from these trials, next slide, Camille. So these trials were performed in rural regions of Europe. Almost all of these patients were more than an hour from a comprehensive stroke center or level 1 stroke center. In fact, if you were within 30 minutes of a CSE, you were generally excluded. In the way that these healthcare systems are set up, they don't put primary stroke centers across the street from comprehensive stroke centers. Now, that's not the way our system is here in the US. We have a much more fragmented system. And with different healthcare systems working in the same metropolitan area, it's not uncommon to have multiple primary stroke centers all within a 30-minute radius of a comprehensive stroke center. The other aspect of this is the primary stroke centers in the RACECAT trial all were managed out of the central comprehensive stroke center. Okay. But what happened then is that they had a incredibly fast door to needle time for IV thrombolytics of 30 minutes. That's rarely seen in the United States. So the EMS agencies in RACECAT also were not at the same level as some of our very high quality paramedics and EMTs. They didn't even start an IV. So you're comparing rural parts of Europe with long transport distances to comprehensive stroke centers and bare minimum field support to higher level field support, more densely populated areas. In fact, the trialists behind RACECAT would even say, no, if you're within 30 minutes of a comprehensive stroke center, we don't even need to do a trial. You have to go to that center. So let's go to the next slide and take some time to think about what we can do. We've provided some resources, right? So if we take a look, we have the stroke scales for EMS mobile app, and we're constantly updating this. If you have a scale that your region uses that is not on the app, as you can see, we've got LAMS, RACE, CSTAT, FAST-TD, MEN, VAN already on the app. If there's a scale that your region uses that's not on the app, please provide us the feedback. That would be great. Let's go to the next slide. You can find it on either the Google Play Store for Android or the App Store for iOS. And we also have on our website EMS-specific resources. And we really want to engage and work with the EMS community nationally because we truly think this is an amazing opportunity to help patients. You all are the medical professionals who have the first contact with the patient. And those of us who've done EMS outreach in our area, we know how passionate you all are about helping your patients and how much you want to help. And that it's got to be frustrating on your side as well. And I think if we work from our side on the hospital and physician side and from EMS on the pre-hospital side, together we can continue to impact change in these regions. Let's go to the next slide. So what can you do? Well, obviously get the app. That's great. Talk with your peers about triage and transport protocols in your area. Follow us. Invite neurointerventionalists like us to speak to your teams on the ground. If you reach out, we can help perhaps even connect with some neurointerventionalists in your area if you're not aware of who they are. And if you email Camille, we can get you any campaign materials or help you speak with stroke specialists and neurointerventionalists in your area. So at this point, we'll happily open it up. There are a few questions that I already see in the chat, and I'm just going to kind of look at them real quick.
I also am going to tell everybody these slides will be available. I know that was a question in the chat.
Yep. Yep. All right. So what is the reference that explains how the death of neurons in every study was? So that'll be in the slide. So that's from Dr. Jeff Saber from UCLA. He's an internationally renowned stroke neurologist. And if we go back to that slide, or if you grab the slide deck, it's a paper from the journal Stroke, and that can give you the details on how that was derived. And then there's another question here that says, yep, I'm lucky to live in a dense hospital system, Northeast Ohio, less dense. Stroke-rated hospital is important, but if I go to the closest primary, it would take 4 hours transfer to comprehensive. It's only 15 to 30 minutes additional. Our local medical controls argument is not to overwhelm. Are there processes being developed to improve transfer time? So this is the biggest challenge that I was saying, is that in our data, over 5.5 years, you cannot make the PSCs faster. Literally, without triaging in the field, the time to thrombectomy from the time, so that encapsulated the data that we did in our region. We looked at the time the truck left the scene, so scene departure to treatment. And scene departure to treatment there was no way to speed it up without actually going ahead and going directly to the Comprehensive Stroke Center. Other questions that anyone has that someone wants to type in the chat?
I would say that it is true that the American Heart Association has set a target that in the PSC the patient should leave within an hour and a half or an hour, but it's very hard to achieve even within our centers the same way we've been trying, and it happens occasionally where they're super quick, but it's very hard to achieve. I think there is a ceiling where you're going to spend at least 2 hours, I would say, on at least 2 hours on average there.
And just to piggyback on Dr. Fifi's point and the other point that was raised earlier, our median door in, door out time in the data that I presented from our region was 86 minutes, which is very reasonable and pretty fast. So we were already at pretty fast. Then that would be the goal.
Yeah, 4 hours is they can get
4
better.
hours is a long time.
Yeah.
So the question here is if the patient has a positive van transport to comprehensive stroke or primary with surgical capabilities to remove the occlusion. So that's a good question. The primary with surgical capabilities is often thought of as a thrombectomy capable center or sometimes a level 2 stroke center. And so these centers can do the thrombectomy procedures. They're not typically able to manage intracerebral hemorrhage or treat things like brain aneurysms, which can bleed into the brain. But thrombectomy capable centers can be useful, especially if, say, you're in an area where the closest comprehensive stroke center is an hour and a half away. To have a thrombectomy capable center within 15, 20 minutes can be very helpful for patients. I think the challenge would be if you can go to either in the same amount of time. In general, comprehensive stroke centers would have more capabilities. Yep, and there's a comment in the chat for finding the last known well is always a challenge on scene. That's totally true, especially because families sometimes will give you the time that they found the patient as opposed to last known well. And so that's why we always ask, do your best to identify the last known well. But if you can grab a family member cell phone of a reliable contact and put it in pre-hospital notification, our stroke team members will often reach out to the family member and work on getting clarification on that as well. But we completely agree that can be a real challenge to get an accurate last known well.
Great. Are there any last questions? If anyone's typing, we want to give you a chance to put them in. No? Awesome. So Rio just put in the chat information about the CE credit. We will be sharing with Rio the presentation slides, and we just recommend that you reach out to us. Again, we'll have Camille's email in there. If you have any questions or would like a neurointerventionalist in your area to come speak to your team, specifically because there are nuances as we talked through based on region, and we want to make sure you feel comfortable in how you present this learned information or ideas to your leadership. So we are here for you, and just email us if you have any questions. And in the meantime, please let Rio know if you have any questions on CE. Awesome.
Thank you, everyone, for your
Thank you all.
attention.
Thank you.
Thank you all so much, and thank you all so much for presenting today. This was absolutely fantastic, and we appreciate it. Thank you.
Thank you. Take care.